on YouTube, so it's not that bad. All right, so welcome, guys. It's really awesome to see you and have you guys on here. So, so today we're gonna kind of go over pharmacology, go over kind of the course of if you guys have questions on the course itself, and then go over pharmacology of course as well. So, so yeah, I kind of leave it to you guys on questions first, and then if you guys are too shy to have questions, of course I'll start entering in my own agenda too, but this is your time to utilize me and throw stuff at me. So any questions so far on the course itself, on how it looks, how you're supposed to kind of do stuff itself, anything like that?
We get to do quizzes today?
We don't have a Mentimeter today.
Okay.
Maybe at the end I'll like grab one and we could just do it for fun.
Because I feel like the quizzes is what really helps me to like soak up, did I really get this or did I not get it? Because I feel like sometimes on the courses themselves, I'm like, oh, I got that question wrong. I'll get back to it later on. But the thing is, I never get back to it. I never actually take the time to go back to it. So yeah, that's just me.
Yeah, so like with each week that you guys have, so you guys have, like the pre-test when you go in. So it's kind of weird how I say it, but I'm just going to say it. So when you go in and you take the pre-test, it's okay to not do well on like the pre-test, right? Like you're just testing what your knowledge currently is. So when I look at it initially, like it's fine to just put in your knowledge. You guys don't have to be like, oh my gosh, I have to get 100% and look up all the answers. Because if you start looking up all the answers while you're doing the test, you're truly not taking the test like with your own knowledge. So just go ahead and take the test or the quiz that you have and put in your own knowledge. And then whatever you don't get right, then okay, I need to kind of like look this stuff up and kind of get that knowledge base back, or ask if you still don't understand. That's when you kind of either flag that question. There's like a flag button and it lets me know like, hey, a lot of these people have questions on this particular question. So we'll go over it in our Zoom session. And then, or just kind of like notate what question it is, just kind of say, all right, we need to go over this question in the Zoom. So that's when you guys can bring it up to me like, hey, can we go over the question about this dog who had fleas or whatever the question is. And then we can chat about it. Or if it's really important, you guys can always like message me on Facebook about it really quick, or, email me or whatnot. And I try to get back to you pretty fast if possible. So, and then once you guys kind of go through like, the lectures and all of that through the week, you guys can always, once you get all of that material, go back to those quizzes again, because you have 3 attempts to take them, and try to retake those quizzes again with that new knowledge base, right? And so you can take it that week. You can go back to it throughout the course if you'd like. And then even after the course, I usually give you guys a couple weeks additional to go through it, because a lot of you guys are taking the test, whether it's, a little bit after the course is done or whatnot too. I give you guys a little bit of a grace period afterwards too. So you guys can go back in and kind of play around with the quizzes again and just retest your knowledge. So don't feel like you have to get it all done and take the test 3 times right in a row and stuff like that. So it's set up like a course, like you're in school, but it's not really in school. I just kind of made it so that you guys have some sort of structure. I know, hey, we need to get this done in some sort of fashion of 8 weeks, because that's how we're working. But I want you guys to feel like you still are able to kind of go back and retry things again, if that makes sense. Make sense? Sort of? Yep. Cool. And feel free to ask questions all the time. Like there's no dumb question, really. I have asked questions before that I was like, yeah, that was a blonde moment, or, you know, like that kind of thing. But it's okay. Like if someone else is going to have the same question, it's absolutely true. Like someone else is going to have that question. And so go ahead and ask it. Oh, hi. So, let me just mute that really fast. Where's my mute? Where are you? Oops. It's like, sorry. There we go. So, yeah, so if we, all right, who has all the noise in the background? All right, so yeah, if we, yeah, so just feel free to ask those questions. There's also a project that you guys have too. Did you guys notice the projects on your page as well?
The notebook, you mean?
Yes.
Okay.
Everyone kind of.
Yeah.
Everyone saw it? Okay. So I'll share my screen really quick in case anyone missed it. So the project is kind of, again, it's independent. You know, I can't like force you to do it, but it's highly, highly recommended, right? So I did this with my students when I was teaching in school, and they use it in practice. And it's really helpful if you do it right. I'll say that. So this is not meant to have you guys rewrite a textbook. This is meant for you guys to take it and write down just like cliff notes, basically. So notes that are going to help you remember certain things. And so that way you can go back to it at any point and just remember like the really basic things to, you know, look at it really fast and go, oh, now I remember what that drug does. Or, oh, now I got it. Like the quick, easy steps to things. So as we go through each week, this is going to be the easiest way for you guys to study, is to write down the things that we talk about, the things that you're learning as you go. It doesn't have to be a perfect notebook. So if you guys make, you know, mistakes in the notebook and you need to scratch stuff out, or, you know, if you're doing it in pencil or color pencil or something like that, that's totally fine. You can always make this as your rough draft, and then do one later if you want to keep that as a keepsake, so that you don't feel like, oh, well, I'm so behind in this notebook, and that you never get it done. So please keep up with it, because it's going to be really helpful to you. So you can, you know, I have it like kind of listed out in categories, but you can put your notebook together any way you want. So just as long as it's there. But these are going to be really helpful, especially like so that you know all of your fluid rates, and like, you know, all of the ongoing losses and how to do that. Conversions, of course, are going to be really important. So we come up with really fun ways to learn that kind of stuff. Same thing with medications, like how you can remember these medications and like the fun ways to remember them, because it's hard to just memorize things, right? So how can we remember those things? So just like writing down little simple things like how to remember the benzodiazepines as like, you know, diazepam, imidazolam, that one works faster than the other. And so one's like a sprinter and one's a cross-country runner, right? So like I've taught my other ones in the past, like who's the cross-country runner compared to the short distance runner, because one starts faster and then can't run long distance. So that would be diazepam. And then the cross country runner kind of paces itself. So that would be midazolam. So we like talk about stuff like that. So we make up like little stories about drugs so you guys can remember them. I mean, when I taught in school, the way that we had them remember drugs was we named our rats after like anesthetic drugs. So, but I'm not gonna like make you guys go get rats and name drugs after them. Although that would be fun, right? They're great pets. So yeah, we'll talk about stuff like that. So like that would be something to write in your book, like cross country runner, midazolam, you know, short distance runner, diazepam, and then it like clicks in your brain really fast, and you can remember so much more. So like stages and planes of anesthesia. So how we remember those things, it would be like drawing certain things, you know, just really quick stuff. So you don't have to be an artist. My drawings are god awful, but it's fine as long as you can remember certain stuff. So we'll go over that kind of stuff on Sunday, so that you guys can remember that. And same thing with hematology. So like I say in here, heartworm life cycle draw. It just clicks in your brain then. As you're drawing, that stuff clicks into your brain. So, and then emergency drugs, like knowing the naval drugs. So that should click into your brain. Like, what do those drugs stand for? Did you guys remember, like learn about that?
Mm-hmm.
Yeah. So
I don't know if I can totally remember what they all are.
Yeah.
You can put down the ET tube.
Correct. Good. That's very good. So those drugs go down the ET tube. So what does anyone remember what the ones they stand for?
I want to say
Naloxone.
Okay, naloxone is the first one. Good. And then what's the A?
Atropine.
Good. Any guesses on the V?
Vasopressin.
Vasopressin. Good. How about E?
Epinephrine.
Epinephrine.
Very good. And then the L?
Lidocaine.
Lidocaine. Very good. See? It's all there. You got it. And you just have to dig it out, you know? Like dig it out of your brain. There's so much that's in that, crammed in that brain after 2 years, right? So yeah, like just being able to remember that. So just writing those things down and putting like naval in there, and then just writing the drugs down and saying can go down the ET tube, and then what's the dosing for those, right? So if you have to put them down the ET tube, what do you have to do with the dose?
Double it.
Double it. So then you're done with your notes on that, right? You don't have to be like a book and write a whole paragraph about it. Yeah, that just seems silly. You might as well get the book out. So it's kind of learning a new way of studying, right? We don't have to get all crazy and highlight things in a book and do that kind of stuff, or feel like we're just reading out of a book all the time. It's more like recall this information that's buried in your brain and put it down on a piece of paper and say, all right, I got it. Plus we talk about it. So there's a ton of different ways that we can study and get this stuff. And then you have a book that you can bring to work. And so when something happens and you're like, okay, what do I do? What drug am I giving? You know, and you can always add to it too. So yeah, this is just kind of the beginner section. You can add more things to it. So if you wanted to do parasitology stuff, I always encourage drawing your parasites. They're fun. You can do any colors you want, you know, make it fun. And then we'll talk too about levels of dehydration, those normal values, all of that. We'll do ECGs, so the beginning sections of ECGs and what that looks like, and all of that jazz. Awesome. Any questions on this? It's pretty easy. You just have to do it. So as easy as you go. So, all right. So let's get to any questions you may have about pharmacology this week.
I'm just struggling to like be able to memorize what each one is for.
Okay.
Same.
Yeah.
And I was wondering, Beth, can we go over the each drug that's on our project book so that we understand like what each are, so we can kind of do like our book together to make sure that we have the right info on each of those things.
Yeah, definitely. Let me grab let me just grab this. And all right. So maybe I don't want to do it like that. No, I don't want to do that. Sorry, I'm just copy and pasting it, and you know, sometimes it is a pain. That works. Okay. All right, so let me share my screen for you guys. All right. Oh, this one doesn't have like a little dot there, but that's okay. Okay, so this is from our your guys' project book. So this kind of covers a bit of anesthesia as well. So when we're talking about certain drugs from anesthesia, so we're gonna talk about first our like tranquilizers that we use for anesthetic, or I guess in general we can talk about. So what are the drugs that we use for our tranquilizers?
Diazepam?
That guy goes in a different category. Sure, it's like a sedative effect, but there's a different type of tranquilizer that we would use. It's a phenol.
Yeah,
Acepromazine, very good. Acepromazine. So we'll put that guy in there. You guys get to see my horrible handwriting. Awesome. There's another drug that fits in there with acepromazine, but don't use it very often. But it also helps with like GI related as well. Yeah, good. Chlorpromazine, right? I know I haven't used it in like a million years. Chlorpromazine.
Could you use glycopyrrolate for that?
That is in a different category as well. What category does that one fit in? That's
anticholinergic.
Yeah. So way to throw that one out. So we can put our anticholinergics down here. So glyco, and I have glycopyrrolate. I hope I spelled that one. There's 2 R's in there, don't worry. So there's 2 main ones in there, right? So glycopyrrolate, remember in this one, there's also cross-country runner, and I'm not a runner, so I don't know why I do this like metaphor, I guess, but whatever, it works. Glycopyrrolate is the cross-country runner, right? So long distance runner. I hate writing like this, long distance runner. Who's the short distance runner?
Atropine.
Yeah. So we have atropine. So atropine like works really fast. Like it works almost right away, but it doesn't last that long, right? It only lasts like 20, 30 minutes. But glycopyrrolate, it takes its time to work, right? It doesn't work quite as fast, but it lasts for a longer stint of time. So if we're going to do like a surgery that's going to take a long time, So if you're doing like an orthopedic surgery and or like a back surgery or something like that, you're probably going to want to use glycopyrrolate versus atropine. But if it's like an emergency, we're going to choose atropine, right? Does that make sense? Awesome. And those guys pop up fast. So if you're like, oh gosh, his blood pressure's down or his heart rate's really down, and then you like turn their ISO or SIVO really down because you're trying to get their blood pressure up, you better be quick to realize that if you gave atropine, that they might pop up off the table while they're in surgery. So beware that you might have to turn up their ISO or SIVO so that they don't pop off the table. Seen that happen. So those are their anticholinergics. So way to throw out that category too. So very good. Okay, so we have tranquilizers. Very awesome. All right, benzodiazepine. So someone mentioned one earlier. We have our.
Midazolam.
So we have you said midazolam.
Midazolam.
Oh, good. So midazolam.
I feel like there's diazepam in there too.
Good, and diazepam. So one is a cross-country runner, and one is the long distance runner. One is a long distance runner, and one's a short distance runner. So which one is the long distance runner?
Midazolam.
Good. So long distance. And then which one's short distance then?
Diazepam.
Diazepam. Now, here's the curveball. Is there a reversal drug?
Narcan.
Yes.
Okay. So what is the generic name? Remember, we have to go generic name for benzodiazepines.
I want to say Yohambine so bad. But I don't think that's it. I just like that word.
But that is a reversal, so keep that in mind. I love
Naloxone?
that drug, so.
Would it be naloxone?
No?
That's under opioids.
Bloom something.
Yes, good,
Flumazenol.
good. Yeah. Flumazenol, right?
What is that? Flumazenol?
Flumazin. I have to check its spelling really fast. I always Flumaz. ENIL. Okay.
And that's for all benzos?
Yes.
It reverses all of them?
Flumazenol. Oh, I did spell it right. Okay. Look at that. Now, this one has a couple different terms that we can use. So, or a few, I should say. So we can call them cyclohexamines. We can call them dissociatives, or they're also termed as NMDAs. So that's like the newest term I'd say is NMDAs. So you can hear all three of them as well. So I'm wondering, did I spell this weird? I did. Okay. So we have a couple of them.
Ketamine.
Good. Look at you. You're on it. Just like, yes, I got this. All right. So I'm sorry.
When she said ketamine, I just had Valium that popped up in my head.
All right. Well, what is Valium though?
Diazepam.
Good. So there's a reason, right? There's a reason why those two go together, right? In your head, ketamine and Valium.
One's a muscle relaxant.
Yeah. So why? Why do we do that?
Because ketamine makes them all stiff.
Yes. So that's like the side effect, right? Is ketamine's great to use because it's a dissociative. So it makes you like really feel good and weird and whatever. All right. So it's really good to use. But of course, there's pros and cons to drugs. And one of the con is the fact that they have muscle rigidity. And so we need to give them something to help with that muscle rigidity. So we look at our drugs and we go, oh, we can give diazepam to balance that out. So we give Ketval, right? That's our term, Ketval, or ketamine and Valium, or diazepam, as we say. So that's perfect. Good job. Now, what is the other drug that we also use that is an MMDA, dissociative, or chlorhexamine as well?
Tilletamine.
Tilletamine, very good. So we have tilletamine. Oops, why is my pen being weird? Tilletamine. All right. So we have, and what is like the brand name that we typically use?
The Tilazol. No.
Tilazol. Good.
Is it?
Yeah, Tilazol. Good. So when we have tilletamine or Tilazol, in Tilazol, what does that contain? Tilletamine, right?
Xylosine.
And Xylosine. Good. So again, it has tilletamine because tilletamine is going to have the same side effects as ketamine, but it also has a benzodiazepine already in it. So we could technically just use Tilazol for our patients, which people do, or you could use it as a combo with a bunch of other stuff. But you don't have to add, like ketamine, you don't have to add an additional benzodiazepine because it already has it in it. So great job. Look, Sheila, you're on it. You could do all this.
I have a question. I'm sorry.
Yeah, no, you're fine.
So is ketamine and tilletamine, does that have good skin and limb analgesia, but not visceral, or is that something different?
So visceral pain, so as you know, probably visceral is going to be more organ pain,
Yes.
right?
Mhm.
And then somatic pain is going to be your like
Skin,
bones and
limbs,
yeah, right. So I would say that you're probably going to have, gosh, I mean, there's pain relief, but it's not as great as, other actual pain relief. I would say.
So you would think it's being more somatic then?
Yeah, probably.
Okay.
Yeah.
Okay.
And yeah, I think it's going to be more somatic actually. Yeah. Great. So that's a great question. So when we talk about alpha-2 agonists, so these are my favorite to talk about. I don't know why. We have alpha-2 agonists and then antagonists. Okay. So we're going to be talking about two different types of drugs, but they go together. So yeah, you guys, you like these, right? So I don't know why they're so fun to talk about. So alpha-2 agonists. So let's talk about those first. So we have two alpha-2 agonists that we utilize the most, right? So what are those?
Is it dexmedetomidine?
Yeah, so dexmedetomidine.
Xylosine.
And then xylosine. Good. I put like two eyes there. Yeah, and then xylosine. So technically we have like medetomidine too, but now we use dexmedetomidine quite a bit more. So now you guys are like the new generation of dexmedetomidine. I came from the generation of medetomidine first, and then they came out with dexmedetomidine. So dexmedetomidine has a teeny bit of pain relief in it. Medetomidine, not necessarily. So, and medetomidine itself created more effects of that drop in blood pressure and all of that, where dexmedetomidine still has that vasoconstriction, but not to the extreme level that medetomidine did. So it's quite a bit safer than medetomidine. So, and then we have xylosine, right? So xylosine is a pretty old drug. We've used it for a really long time. It's used a lot in large animal as well. But they both have a complementary drug that goes with it. So this is these are fun medications to utilize because they have a reversal. So you can wake up your patient right afterwards and they can go home pretty much, I don't say right away, but they can go home quickly without feeling like super after effects. So like normally if you are using Propofol, they're still like really sleepy, or if you had to use gas, they're still really sleepy. So these are really good drugs to utilize. So with the reversals,
Would be antecedent.
all right.
Anaphamisol.
Good. So Anaphamisol. So you're right on the antecedent, right? But that is the brand name. So we have to say generics, right? Because I'm not going to say like we're the professionals here, but it's better to be talking about generics because you never know if you don't get the brand name and you get a generic. It's good to know that. Plus they always, oh gosh, you know how many carprofens are out there now? It's not just Rimadyl anymore. So then there's like 8 different carprofens. It's crazy. So, all right. So we have Anaphamisol. So Anaphamisol.
Yohimbine.
I cannot spell these. I must be like losing my mind here. All right. And then we have Yohimbine.
Here we go. There's my Yohimbine.
I know. It's my favorite, right? So I named a baby after this drug. And I got a gift for the baby as well, a puzzle that said Yohimbine. It was my student's baby. It was totally fine. His girlfriend didn't like it, but that's too bad. So now we have to go, okay, what reversal goes with what drug, right? So this is the easy way to remember it. If you're like, I'm lost, I can't do this. Which drugs are in the beginning of the alphabet and which drugs are at the end of the alphabet?
Dex and Anaphamisol and xylosine and Yohimbine.
Yeah, right. So Anaphamisol goes with dexmedetomidine because they're at the beginning of the alphabet. And then xylazole and Yohimbine go together because they're at the end of the alphabet.
Wow, it just clicked.
There you go.
I don't know how many times I heard you say that, but this moment I just went, ah.
Yeah, you got to find the easiest way to do it, right? So the deal with this is like knowing, okay, agonist means agonist, she's tired. She's an old lady. She wants to go to bed. She wants to sleep through her day, whatever. She's so tired. So these drugs, they make her go to sleep, right? These 2 drugs. And antagonists, you got to think of, they're antagonizing her. They're like those little kids that just want to bother you all day and whatever. So they like come in and they wake you up. So that's these guys. They're antagonizing agonist.
They're anatomic bombs.
Yeah.
Wake up.
Right. So that's why these drugs are called that, right? So that's how you kind of think of it. So we got to make up little stories about drugs to kind of keep it fresh in our head. All right, so Hypnotics. I don't know that people talk too much about Hypnotics in school, but one of them we use a lot in practice.
Propofol.
Propofol, good. So that's like one of our most favorite drugs, right? Is Propofol. We use it all the time. So what do we know about Propofol?
You don't want to put it outside of the vein.
Yeah. Which one especially? There's Propofol and then Propofol 28. Oh, we're getting technical here.
That's a good question.
Contain egg whites and soy.
Oh, wait, I couldn't hear. I'm sorry. Casey, what'd you say again?
Oh, it contains egg whites and soy.
It has. Oh, are you talking about the egg and
Soy.
Propofol? Okay, yeah. So okay, perfect. Yeah.
Has
So
allergic reaction.
yes. So yeah, the in Propofol itself, the ingredients that keep it. Oh gosh, now I'm trying to think of how you word it. How it is kept essentially. It can only, after it's open, it's only good for 24 hours essentially.
The shelf life.
Yeah, it's egg and soy based, right? So, and it doesn't matter if you refrigerate it or not. So that's like the big myth, is that if you keep it refrigerated, then it lasts a little bit longer. It actually doesn't matter. It's 24 hours. So, now what about Propofol? So also in the vein, right? We're talking about the vein. That's Propofol. I call it the blue Propofol. So the 24-hour Propofol, not the 28. That's the one you'd want to keep in the vein for sure. And then if you accidentally get it outside the vein, you just have to dilute it down. So flushing just saline, as much saline as possible to dilute it down, which is pretty awful. I feel bad.
Is it a beta blocker?
Propofol?
Mm-hmm.
No,
Gamma receptors.
Okay.
Yeah, Propofol is a hypnotic. So, so we're actually utilizing it for them to go to sleep, obviously. So not necessarily like heart related or anything like that. And then what else do we know about Propofol? Like anything.
Can cause apnea.
Yeah, so it can cause apnea. Very good, especially the blue guy, right? If you give it too fast, right?
Why is it blue? Is it the color actually blue? Like
No, like the label. The label has blue on it. That's why I call it blue.
Mm-hmm.
Yeah, and then the Propofol 28 is like green on the label. So, you're right. So it can cause apnea. So how can we reduce apnea? By using Propofol, we can also combine it with some other drugs. So what is one way we?
I always just give it really slow.
Good, you can give it slow. And then what's other ways that you can do it? Can you combine it with another drug, not necessarily in the same syringe, but like giving something else as well to reduce apnea?
Would it be dose to effect?
Yeah, so you're dosing to effect, of course. Yeah, so this would be called, rather than the bolus effect, right? You're titrating it, so giving slow amounts, right? But there's another drug that we especially can use before giving Propofol to like reduce the amount of Propofol we give to help with apnea. So a lot of times we'll give a dose of diazepam to our patients, and then we'll give our dose of Propofol, and it actually reduces the amount of propofol we have to give, and also reduces the risk of apnea. So it's kind of nice. You can also do midazolam too. So, but a lot of people use diazepam, just kind of whichever you have on stock. So good. That is propofol. Another thing with propofol 28, especially, what is another thing we try to avoid if possible, if giving propofol 28?
Do not give to cats.
Good. So if we can, try not to give to cats, right? And what's the reason behind that?
They go crazy.
It's toxic.
Good. So there's a toxicity to it. What in propofol 28 would be that toxicity?
I think it's an alcohol.
Yes. So the preservative in propofol 28 is alcohol based. And so that is toxic to cats. So they actually start lysing the red blood cells in cats. So it hasn't been necessarily proven that it is extremely toxic, and it hasn't been proven that they can get a certain amount. But they have shown that if you give like a 1 dose effect, that it is somewhat safe for now. But try to stick to just giving the actual amount of propofol, and not like, say the cat is still not down with the dose that you gave, not to do additional dosing afterwards. So yeah, be conservative with propofol 28 with cats. If you can avoid it by using the regular propofol with cats, then utilize that. So I tried to do that because I don't want to risk anything. What is another hypnotic that we have? If you're in a practice and have this, you're super, super lucky. It's extremely expensive, so you may not use it that often. Any ideas? We use it for cardiac patients, if possible. Or block cats. Why block cats? Weird. Cardiac patients or block cats? How do they fit together?
Does
It
something
starts
to do
with
with potassium?
I'm sorry.
Does it have something to do with potassium?
Not
Outfit?
calcium.
The potassium?
Oh, potassium, yes. So what does the potassium do with cats?
Slows down their heart.
It can cause arrhythmias, but yes. So it gives the effect of the fact that they're having heart issues at that moment. So yes, they're essentially having cardiac issues. So we need to kind of be conservative with our anesthesia protocols who unblock them, right? So yeah, we'll use this drug if we can. So okay, so this hypnotic drug, I'll give you another hint. This hypnotic drug starts with an E.
Etomidate.
Good. Etomidate. So I like this drug a lot. It's really great. So etomidate. So if any of you guys have this in practice, so typically with etomidate, we do pair this drug with another drug as well. Usually it's a benzodiazepine too. So they are nice and relaxed when they go down for anesthetic procedures. But yes, we'll use this for cardiac patients a lot of times, critical patients, like really critical patients, or our urinary obstruction cats and stuff too. So, but it's extremely expensive. It comes in like tiny, tiny vials, and if you don't use all of it, you have to throw it away. So it's like a little gold. You treat it like gold, essentially. So very good. All right, so we talk about barbiturates. So all of the barbs you can think of, right? So think of the drugs that have barbs in it.
Pentabarbital?
I'm sorry, you said phenobarbital?
Yeah.
Or phenobarbital? Okay. So we have phenobarbital. And what do we use this for?
Seizures.
Sedation?
Seizures.
Yeah, it's an anti-convulsant.
Anticonvulsant.
Anticonvulsant. You can sedate them with it if you have to phenol load them. They'll fall asleep eventually, right? So, yeah, so it's for anticonvulsants, right? So we use this as like probably one of our number one anticonvulsants at this point. Yeah. Now, what do we monitor when we have animals on phenobarbital?
The levels, the phenobarbital levels.
Good, phenobarbital levels. What organ
Liver.
system do we really monitor though when they're on this drug?
The liver.
Sorry, what'd you say?
The liver.
The liver, very good, very good. So yeah, when they're on this drug, we definitely monitor liver values too, just to make sure there's, chronically, there's no liver issues and stuff. So very good, very good. And yes, we have to monitor phenobarbital levels. Why is that?
Because it's fat soluble.
Okay. And then we need to make sure there's a range, right, for phenobarbital levels. So we need to make sure that they're in a therapeutic range, right? So we'll check and go, okay, are they at a good level to make sure that we're not going to have them have seizures, right? Or if they're not at that good level, we'll raise the amount that they're on. Or if they're at a too high level, we'll go, okay, we don't want their liver to like get injured in any way, so we'll back them down a little bit. So that's a big reason why we kind of monitor that. But very good, that's awesome. All right, what's another barbiturate?
Is Pentabarbital?
All right, we got Pentabarbital. Someone else said something too. Pentobarbital. Who else said something? What'd you say? What'd you say?
Is Theopental?
Yeah. Yeah. The one that we don't really use because it's like super scary, right? But yes, absolutely. So, all right, let's talk about Pentabarbital. What is Pentabarbital?
Euthasol.
Okay, great. We use it for
It's
euthanasia.
used in lab animals too.
Yeah, yeah. So now this used to be used as an anesthetic drug, like back in the day, until they realized like animals were dying, and so it probably shouldn't be used as an anesthetic drug. Live and learn. So yeah, it's used as a euthanasia solution. Now, key thing to know is you guys should kind of know for the future. Probably not, I don't know if how much do you have to know about, honestly, some of these you'll have to know what is a controlled drug, like in here, right? Which ones are controlled. But good to know just as an FYI, if you have Pentabarbital itself just alone is a Schedule 2 controlled drug. But if you have a brand that's just like Sleepaway and it has Pentobarbital and another, additive in there, that would actually be a Schedule 3 drug. So it's interesting how they are, put in those categories. So of course, when you guys are handling any controlled substances, Schedule 2 drugs have to be handled just a little bit more delicately in the practice than 3s, 4s, and 5s. So it's good to kind of know that stuff. So
Question. The control,
Oh,
I've
you
never really
Canadians, I don't know. So
yeah, I never really understood the
Yeah.
schedule because I like in my
your guys' is
just like
so
a book
weird.
where they talked about like the the schedules, and I'm like, I have no idea what is what. So
Yeah, your guys's is so different. So I'd have to figure yours out I have to look it over again to figure it out.
can we do like a session just on the schedules?
Just on the Canadian schedules?
No.
Both, just like compare both schedules. 'Cause I just
Yeah.
get so confused.
Well, I have a little thing where I did just a little bit, but yeah, I'll have to do a little bit more learning of my own. I did some digging and then I was like, all right, I got it. And then now I have to go back and review it again because your guys' thing is a little weird to me.
Is there a good place for us to look up a list of what they're all scheduled as so we
Yeah.
can correctly in our notebook?
Yeah, I think I do have it in the Moodle, in Moodle already, but if not, I'll double check if it's in there or not. Otherwise, I'll put something in Moodle for you. Yeah,
Okay.
yeah.
Pretty sure there's
It's in my
three
head.
sections on it.
No, I'm just kidding. I'll give you my brain for you. No, but I'll
That'd be
get something
amazing.
for you. Yeah, no,
Yeah.
no, you don't want it. I
like that.
swear. Yeah, I swear you don't want it. But no, I'll make sure it's either in Moodle or I'll get you something too. So
Okay, thank you.
yeah. But it's good to have for the future, just for you guys. And then I mean, always keeping up with certain things too, because they change stuff as you guys progress. So like one thing is like gabapentin is a questionable thing where some states are putting it as a Schedule 5 already, and then some aren't, but it's questionable. I guess I should say most aren't, but they're questioning whether they should. So it's always good to like keep on like researching it each year. Like, okay, are they gonna do it or not? Like Prowin has been a questionable one since I can remember, probably since I started in the field. So many practices just kind of put it in, they keep tabs of it, I should say. So it's good to just keep track of that kind of stuff. So, okay. And then Theopental. So what do we know about Theopental?
Only give it.
That's what you give to greyhounds.
Okay, good. And all of these, the barbitals, right? We have to be really careful with sight hounds, right? There's a reason for that.
Do they metabolize it too fast? I don't remember.
Yes.
It has something to do with their body fat.
It's fat soluble.
Yeah. So yeah, it's because they have no fat on their body, right? So yeah, they metabolize it because like super fast because they don't have enough fat on them. I mean, I wish I had that issue, but whatever. So yeah, I mean, we have to be very careful if they need to be on any type of barbiturate. So, so yeah, very good. And then, so Theopental also has an issue with outside the vein, right? And so it can do some major damage of sloughing and necrosis and grossness. Necrosis and grossness. I like that. Not used really.
No.
Not common. Yeah.
I was gonna ask. Yeah. I'm not gonna- no.
No, which is fine. Very fine. So Pentobarbital is short acting or long acting?
Long acting, I would say.
Short acting.
It's short
Short
acting.
acting, yeah. Yeah. And then Phenobarbital?
Long acting.
Long acting, right? Very good. Okay, so then we have here, we're gonna need some room for opioids. Opioids. What kind of opioids do we have?
Sorry, I just want to recap on. So you said Pentabarbital is long acting?
Yeah.
So long, and which one was short acting?
Pentobarbital. Yep. We don't need it to work that long.
Got it. All right, opioids.
Okay, so our opioids. Let's start from the least I like to say least effective. But
Tramadol?
okay, good. Yeah, okay. That's
Yeah.
good. I wasn't even thinking that, right? But you got it. Okay, that was perfect. So that's actually funny. So Tramadol, I love it. Tramadol, very good. So Tramadol comes in what form?
Tablet.
But
Tablet, right? Unfortunately, right? That sucks.
yeah.
But good. So we have found over the years, we've done Tramadol just all by itself, and we found that it's not as effective as we thought it was, but we still use it in combination with other pain medications, and it can have some effect or better effect in combination with NSAIDs or like gabapentin as well. So we still use it in that effect. So it has a purpose, I guess. Not as great for like major pain relief. So awesome. You guys still keep, so a lot of people don't keep it in practice anymore at all. So you guys who are in practice?
No, my doctors are done with it.
Yeah. There's a lot better pain management therapies I have seen. So, but there are some that still are like, well, we'll keep going with it. So, all right. So next one.
Hydromorphone.
Okay, we have a couple before.
Butorphanol?
Butorphanol, right?
Yeah.
Good. So I always say, this is like waving the bottle in front of an animal, and that's like the pain relief you get. You get more. You get more than that. But like, I mean, it's not a lot because it doesn't last very long. The pain relief doesn't last very long for procedures. So, but what's really good about this drug as well?
Can be combined.
I'm sorry.
It can be combined.
Yes,
with other
you can.
medications.
Absolutely. Yeah, we put it in a ton of different combination drugs too. So that's the really awesome thing. Absolutely. What other thing does this drug do? As well as being like a pain relief drug.
Oh, it's a mild sedative.
Good. Yeah. It's a mild sedative. Absolutely. A lot of patients come in and they're like just freaking out because they don't feel well, and so sometimes we just need to be like, okay, chill. Let's have you chill and we'll like evaluate you then. What else does it do?
Would it also
It blocks.
beta blocker?
It partially blocks others or reverses others.
Yes. So it's a partial reversal, right? So very good. Very, very good.
Partial reversal of what?
Of other opioids.
Oh, I don't think I ever knew that.
Yeah. Yeah, you can give it to horses. Yeah. So again, like in large animal, it's a good sedative effect to keep their feet on the ground, right? Very good. Awesome. So there's another thing that it does, especially when you have like breathing animals come in that are having trouble breathing. What does it do for those guys?
Is it a bronchodilator?
It's an antitussive.
Okay.
Yeah. Okay. So we can also send it home for animals that have like kennel cough, stuff like that too. So, but yeah, like you have those cats that come in, right? And so it helps with that sedative effect, but it also can help with like as an antitussive for them, because we don't know essentially like what's going on with breathing issues and all of that too. So it can help either way in that effect. So it's nice to be able to use those. So not necessarily the greatest for pain relief all the time, but it has great effects for other things that we can utilize it for. Awesome. So
Is nalbuphine another one?
L-buphine, you said?
Nalbuphine.
Buprenorphine?
Nalbuphine.
A-L-N.
No, Nal.
Oh, N-A-L.
Buphine.
Okay. Yes. I have not necessarily utilized this in practice. So it is, but we don't necessarily, from what I have done, utilize this in practice.
Actually, I've never seen it, but I did learn about it, and I just wanted to know, should I delete it from my brain so I can make room for other things?
Yeah. I'm trying. Yeah, let me just look really quick if.
Would that be the same thing as buprenorphine?
No, it's a totally different drug.
It is an agonist antagonist.
Yeah, it's not. Yeah, it's not buprenorphine though. It's a totally different drug. Yeah, I have not utilized it in practice at all. I mean, you don't have to obviously delete it from your brain, but I wouldn't necessarily focus on it too much at this point. It just might be something that, like, it's just not a common one that we're going to necessarily utilize. So you may see it in practice though.
Okay, so butorphanol would be the one to know.
Yeah, butorphanol is the first one that we kind of will focus on. I'd say that nalbuphine is probably more like buprenorphine, but it's probably not the most common that you're going to see compared to buprenorphine. Buprenorphine you still see the most in practice. So I would say that because I travel to look at hospitals around the country for my normal job, and I have not seen it. So,
okay, thanks.
Yeah, no, I get lucky like that. Yeah.
I keep and I've been like I keep getting buprenorphine and butorphanol like confused.
Yeah,
me too.
Anyone have a mnemonic device for this? Because I know the difference, but
right, like when you see it, yeah.
Yeah.
Okay, so
the way I learned that one, because one is a partial agonist and the other one is, agonist antagonist. The way that I learned partial agonist was Bupre has the P in it, so it's partial. That's how I remembered it. I don't know if that helps or if that makes sense to you.
But or bup. I see what you mean. Okay, so yeah, as Beth is writing them out, I'm like, oh yeah, like I'm spelling them as well. Okay, partial antagonist and agonist.
Okay, so essentially, like how she's saying, is buprenorphine has two purposes, essentially. It's like a magic drug. So it's actually an agonist where it does give pain relief to a patient, but it does not like the fact that there's other opioids in the system. So it will release the other opioids from their little puzzle spot, as I call them, their receptors, and say, nope, you can't be here. And so it antagonizes it and says, you're gone. So like, especially fentanyl. So I always say this for patients that are in hospital. So say you have an animal that just had, usually it's like an orthopedic surgery. And so they get a fentanyl patch placed. And then we are giving buprenorphine after surgery until the fentanyl patch kicks in. That takes like 12 hours. So we're giving that buprenorphine So by the next morning, the fentanyl patch has kicked in. And if we're not paying attention, someone gives the buprenorphine again. And so essentially the buprenorphine goes, oh, fentanyl's on the receptor here, and I don't like it. So I'm going to take it off of those receptors and insert myself there, which we don't want, because we'd rather have the fentanyl there because the fentanyl's stronger and better and whatever, and our patient's going, ouchie, 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 right? So we have to constantly remind ourselves and others, like, hey, we can't do both, at the same time. So so that's what it means by agonist antagonist. So actually buprenorphine was made originally to help, like, oh gosh, now I'm gonna like blank on this, to help with any kind of people who are recovering from any opioid addiction. So that was how they were using it, but then we found that obviously it helps with pain relief too. So yeah.
Okay.
So does anyone, you guys use buprenorphine, like oral or transmucosal buprenorphine currently? Anyone do that?
Mhm. Yeah, we could do
cats.
that. Yeah.
Awesome. Anyone use buprenorphine tablets?
No.
No.
Mm-mm.
Doesn't blow
Compounded?
your mind. So they actually do have tablets now.
Nice.
If you can get a cat to take a tablet, right? So yeah, they are out there. I don't know how expensive they are, but they're out there. Okay, so we talked about the cool things about buprenorphine. Now, buprenorphine is good for, like, what type of pain relief?
Moderate.
Yeah, like moderate pain, right? So like we could do that for like spays, neuters, some mass removals, stuff like that, right? We have some, trauma that comes in that's like not super extensive, like just mild trauma or, that kind of thing. Maybe some mild dog bites, like stuff like that. So yeah, we kind of utilize it for that. We like our buprenorphine. It's good. So buprenorphine is a Schedule 3.
3. Okay.
Yeah. Our butorphanol is Schedule 4. Put that in there. All right. I think tramadol is Schedule 5. I'm pretty sure. I would assume this one's a Schedule 3 too, but I'd have to double check on that. So,
You said 3 or 4? I thought it was 4.
For which one?
Buprenorphine. You said 3?
Yeah,
I thought it was
it's 3. Yeah.
Butorphanol is Schedule 4 then?
Butorphanol is Schedule 4. Yeah.
Yeah.
Yeah. If we look at all of these, so like, I believe diazepam and midazolam are Schedule 4. Ketamine is a Schedule 3, I believe. And same with tilletamine. Your alpha 2s are not controlled. And then propofol again is not controlled, nor is etomidate. And then when we look,
in Georgia.
I'm sorry.
Propofol is controlled in Georgia.
Oh.
You're right. You're in Georgia?
Yeah.
That's
I don't
awesome.
brag about it.
I help practices out in Georgia. So
So funny.
yeah, that's awesome. I just actually did a practice in Georgia today. So yeah.
So funny. What part? Real quick. I'm sorry.
It was North Georgia. Oh, I shouldn't say the practice. It was in oh goodness gracious. Oh wait, I can find this really fast. I can do this really
It's
fast.
fine. It's
No,
not a
I
big deal.
know
I
it.
just
I know
did
it. I know it. Oh, I just had it too. It was in Buford.
Okay, that's not far from me. Small world.
That's awesome. Yeah. Wouldn't that have been funny if it was your practice? I would have
Right.
died. That's awesome. No, that's great. I love Georgia. I love the people in Georgia. It's so nice.
It's okay. I like it.
No, they're so nice. Okay, so phenobarbital is Schedule 3. All right, so I'll put that there. Schedule 3. Remember pentobarbital we talked about? If it's all out by itself, it's a Schedule 2. But if it's like mixed with a little something else, it's going to be a Schedule 3. So like if it's like sleep away or whatnot. Oh, look, she's like writing things in here for me. Oh, I love it. Oh, phenobarbital is a 4. Awesome. Oh, thank you for this, Josephine. You're awesome. Hydrocodone, yes, you're right. Hydrocodone is a 2. Fentanyl is
1, 2. 1, 2. It's a 2.
It's a 2. Yeah. Yeah. You guys will not have any control drugs that are 1 in your practice because that would be like
Heroin.
Else, yeah. Yeah. So you don't want those in your practice. Don't do that. Great. Thank you for posting this. Including Pentabarbital euthanasia solutions. Perfect. No, this is great. Thank you. I know some of them I'm like, oh, I have to make sure. Ketamine, awesome. And then, wait, let me just double check this. Schedule 2s, Schedule 3s, buprenorphine. I'm just double checking myself here because phenobarbital is a 4. Interesting. And Tramadol is a 4. Awesome. I did not know. I thought that was 5, but great. Thank you so much for posting that. You're amazing. That makes everything so much easier.
I have another question.
Yeah.
What would be a trick to remember like the Roman letter number thing?
It's practice.
Yeah, life.
Yeah, it's practice.
Yeah.
Yeah.
There's no trick to remember that? I get so confused every single time, whether it's the cranial nerve or whether it's schedules. They always put in Roman numbers. I'm like,
You just have to practice it. So,
Okay.
yeah. Okay, so we have buprenorphine. Our next one we probably insert would be.
Hydrocodone?
Okay, let's do that one. So what do we use hydrocodone for?
Coughing.
Yeah,
Coughing
very good. That's
dyspnea.
like our main reason, right? Hydrocodone. It's like a miracle. Seems to work great. So as we said, this is a Schedule 2 drug. And the big thing with like why we say we like Schedule 2 drugs that we have to be cautious with is like when we're recording things for the patients and stuff, and to like kind of know like what to do for the DEA, is that for Schedule 2 drugs, and if you had Schedule 1 drugs, which you won't have, you have to have your Schedule 2 drugs listed, like all of your recordings or logging in a separate binder or just separated out from your Schedule 3, 4, and 5s. So like if the DEA came in, they would say, hi, we'd like to see your Schedule 2 drug logging first. And then if there's any type of like issues where they're questioning things for the Schedule 2s, then they're going to want to see your 3s, 4s, and 5s. So it's nice to be able to give them just the 2s first and then not give them everything at once, because then they're going to look at everything at once. So give them just the 2s in a separate binder, and then you can give them the 3, 4, and 5. So always separate those guys out. So yeah, that's really important. Okay, so hydrocodone is for coughing that we usually give. You can have them in what type of form?
Pill.
Okay.
Liquid.
And liquid, very good, absolutely. So awesome. And then what's our next drug that we can have on our list?
Hydromorphone?
Hydromorphone. Awesome.
Okay.
So what do we know about hydromorphone? Do we like hydromorphone?
Yes.
Yes.
Least expensive.
But it causes vomiting.
Can cause vomiting, right? Okay.
Great.
So-
pain control.
Yeah, it's good pain
But, you know,
control.
analgesic.
It's what'd you say, Casey?
The same thing as you. I said analgesia.
Yeah, awesome. Yeah. So it can cause vomiting, right? At times.
Mhm.
It's good pain control, especially for some higher end procedures. What is another side effect other than like vomiting that you may see with hydro?
Salivation.
What did you just say? Sorry.
The salivation.
Salivation. Okay, great.
Is it the one that causes respiratory depression?
Yes, it can cause respiratory depression. Any opioid can cause the respiratory depression. Absolutely. Yeah, but definitely like these higher opioids, you'll definitely notice the respiratory depression. There is one thing, I guess you'd say respiratory wise, that you can notice in hydromorphone especially.
Respiratory.
Hydromorphone can make them pant.
Okay.
So not that they have respiratory issues,
Okay.
but it just makes them pant. So
Whether it's
so-
dogs or cat, they pant.
usually dogs, that you'll notice them pant. But you want to keep this in mind, especially when you have maybe a trauma that comes in and say they're having like a chest issue, right? You might not want to give hydro because if they had trauma to their chest, you don't want them to exert any more like panting and stuff because they already had trauma to their chest. So you may want to go with some other type of opioid for them at that time because you don't want them to do more damage.
What schedule is it?
This guy's a Schedule 2.
Okay.
Yeah. Check out Josephine's list because it's perfect. So
How do I find that?
it's on our
Yeah.
chat, the chat that we have.
I'm trying to copy it in a Word document and
Yeah,
it
maybe
won't let me.
Oh, yeah, right.
I'm gonna have. Oh, there.
I don't know.
I was like, I don't know where the chat's at.
I know.
Probably
I
Thank
can't
you.
copy paste this.
Screenshot.
Why?
I wonder if I can do it on here.
Copy it. Class 5 Limitol. What's Limitol?
Otherwise, I know that at the end of this, it will, no. It saves the chat at the end too, so I can always just add it to our stuff. So don't worry.
Yeah,
Don't
it's
worry.
not letting me copy it either.
Okay, so I'll save it for everyone, and I could put it in our Moodle or whatnot.
Awesome.
So yeah, no
Awesome.
worries, guys. No worries. We got this.
Thank you,
Technical
Josephine.
issues. Okay, so hydro is great for all of those pain issues and stuff. So after hydro, what do we have? We did miss one, but that's okay.
Naloxone?
Morphine.
Morphine, good. So
Oh, right.
the mother opioid, right? So
Mhm.
everyone stems from morphine, right?
Morphine.
So we have morphine. So
Mama morphine.
yeah, the mama morphine, right?
Yeah.
All right. So why don't we use morphine as much? We used to, oh my gosh, we used to use morphine like crazy. You want to talk about cheap drug, right?
Because humans take them and use them on their own instead of for their pets, and that's
Yes,
counterproductive.
exactly. That's the reason. No. Why don't we use morphine so much?
It's not as potent as the others.
Okay. Some of them, definitely. Yeah. It's more potent than butorphanol, I'd say. But yes, you're right. Like there's certain ones like buprenorphine, hydro is more potent. Definitely fentanyl. Fentanyl is way more potent. But there are some side effects to morphine that we'd like to try to avoid, right? So what are some big side effects that we look at?
I don't know, but we never use it. So I'm like,
I see
yeah.
it every once in a while. I see
Okay.
it here and there. And there are times like even when I was in specialty that we had some doctors use it. And you will see it used in like if you're doing CRIs, you know,
Yes.
like, and stuff too. So like you'll see it MLK bags, you know, your morphine, lidocaine, ketamine. So it's used in those fashions, but not necessarily always as like a pre-med or something like that for
Is it
reasons, right?
bradycardia?
So yeah, you could see it, same reasons like any of these opioids in that fashion, absolutely. But there's certain things specifically. We talked about hydro causing vomiting.
Mhm.
What about morphine? You guys are too young, that's why.
Yeah.
You guys are gonna be
Um,
old like me.
Okay, so
I'm like, be
sure,
old.
vomiting.
Vomiting.
Do they become? Are they too dysphoric? Oh, vomiting, just vomiting.
Vomiting,
Okay.
vomiting. So you talk about hydro making them vomit. Oh my gosh. Morphine, we used to give like their pre-med of morphine, and we knew they were ready for surgery
Ugh.
when they would vomit. Like, and it was like vomit. It was barbaric.
Ugh.
Yeah. I'm talking like 20 years ago. So, yeah. So yeah. So that was our like pre-med, and then you know, of course, they're like really sleepy by then. But yeah, they would like throw up like huge amounts of food and stuff. I'm like, where did that come from? You were an NPO for ever. Came from deep within, you know? So, yeah, very, very major vomiting. And then, what else happens with morphine if you give it IV? It releases something.
Histamine?
Yeah, histamine release. Anyone ever have morphine or had to have morphine?
It doesn't work on me, so they don't give it to me.
Okay.
Yeah, you get itchy.
Yeah, you get really itchy. I know. I felt like I was going to peel my face off when I had it before. So, yeah, you have a major histamine release. And so we try not to give it IV due to histamine release. So yeah, that's a really big one too.
So histamine would make you itchy.
Yeah, so you can have like allergic reaction basically, right? Because it has a huge histamine release.
So morphine would need to be given with diphenhydramine and Serenia.
Yes, exactly. You're treating for the pain medicine, right? So it's just insane. So we have better things to choose from now, right? Like just absolutely better drugs to utilize. Like I could just remember 20-ish years ago or more, we just didn't have. We had butorphanol, but we did not have buprenorphine or hydro or fentanyl. Like we didn't have those drugs. I feel so old. So I'm not old, guys. My birthday's on Monday. I'm so excited, but I'm not that old, I swear.
Happy birthday.
Thanks. I'm only going to be 3 times older than my daughter. She keeps telling me that. So, she's not that old. Thanks. I'm excited. I always love my birthday for some reason. It's not like I get anything, but you know, it's one day out of the year. It's my day. So there. So anyway, but I'm old. So, after our hydro, and then we had morphine, the mother morphine in there. What are our other drugs that we put in there?
Fentanyl.
Fentanyl? Who else said something?
Oxymorphone.
Oh, you want to go crazy here on us, huh? Oxymorphone. So we have So we have Oxymorphone. Again, maybe not a drug we see very often, but it's there, right? And then you've had fentanyl, which, depending on the practice, you may have. And because some practices don't do like crazy procedures or like, just,
Right.
So you may have hydro and then kind of stop from there. But if you have, procedures that require additional pain management, you could do that. So what does fentanyl come in? How can you give it, I guess?
Patches or a liquid, injectable.
Good. Injectable, good. Yeah, a patch or injectable. Very good. And so how long does the patch last?
24 hours.
Does it last for 24? 12?
I thought it was more like a couple days.
Yeah.
3 days.
You're getting
3 days.
closer. You're getting
3 days.
yeah.
Was
So
it like
I
2
thought
or 4
it was
days?
72 hours.
72?
None of us know.
Keep
don't
guessing, guys. Keep
remember.
guessing.
Is it like 2 to 4 days?
You're getting close. 3 to 5 days. 3 to 5 days.
3
Yeah.
to 5.
Yeah. Very good. Very good. Yeah. So awesome. I love the guessing. It's great.
Let's just take the test together, you guys.
Right. Exactly. Yeah. They should do group testing, right?
Yes.
Yeah, absolutely. So yeah, so it takes about 12 hours to actually become effective, right? You can't just slap on the patch and then it starts working. I wish. But to actually absorb into the skin and actually become effective, it takes about 12 hours. But the patch itself lasts about 3 to 5 days. So we usually say to owners, leave it on for, about 5 days, and then they can take that patch off and then discard it. They can throw it just in the regular trash, is fine, because usually there's not enough within the patch to do that much. If they're really worried, or if there's some practices that are worried too, they do ask for them to bring it back and they can discard it themselves as well. It's just up to the practice on how they want to handle it. So I've seen it both ways. So and then injectable, we have done a ton of things with injectable. You can do injectable as just a fentanyl on its own CRI. You do fentanyl, ketamine, and lidocaine, just like almost an MLK. In fluids, you can do it in a syringe pump as well. So we will practice CRI calculations through this course. So don't you worry, I love math. So we'll have fun doing that as well. So now fentanyl, how much is it in its potency compared to morphine?
80 to 100 times more.
Whoa.
Okay, you're close, but yes.
At least that's what my book said.
It's
Oh,
measured
good.
in micrograms.
Yeah, so it really depends. So, okay, you are right in the fact that yes, in what we receive at the hospital is probably somewhere around there, 80 to 100 times more potent than morphine. Now, as you know, what you may see like outside of the hospital can be up to 250 times more potent than morphine.
Wow.
Yeah. So it's crazy. It's absolutely crazy.
It's nasty stuff in the wrong hands.
Yeah. So yes, I mean, it's super potent, and like what we get, and then outside it's just insane. So that's a huge reason, again, why we have had such a hard time with fentanyl. And fentanyl for a small period of time was actually Schedule I drug for like 2 years. And so we had to be really careful with it. So it kind of hurt the medical industry a little bit with just how much we had to regulate it. So now, how about hydromorphone? How many times more potent is hydromorphone than morphine?
10.
10 times. Yeah, absolutely. So we always kind of compare everything back to morphine because morphine is the mother of all opioids. All right, so now when we look at our opioids, who is the reversal, the complete reversal of all of our opioids?
Naloxone.
Naloxone, right?
Yeah.
All right, so reversal. Everybody knows this because we see these videos of stuff. And nalox, I can't even spell this
The
right.
free naloxone kits that they give to humans.
Yeah,
They get.
right. So yeah, we see the videos of people who carry Narcan or naloxone with them. So this one is pretty easy to kind of remember of the reversal of naloxone. So making sure to have naloxone in practice is really important too, because you know, you just never know if you might need to reverse any of these drugs on your own patient. So as you know, you can give naloxone IV. You can always give naloxone intranasally as well. Another way too, I forgot to tell you guys, if you have an animal who comes in with a seizure and you guys are, what drug do we give for animals who are having a seizure?
Diazepam. Intranasal.
You ruined it. You ruined my thing. Yeah. So yeah, we can give them diazepam, right? Because diazepam starts working quickly, right? Rather than midazolam. Midazolam takes its time. So we can give diazepam first. So if you can't get it in the vein right away, a lot of people do rectal diazepam, right? Which is messy, and then you have to deal with the poo factor. Like, did it really get absorbed? Because there could be a lot of poo going on back there, all of that. So if you can get it intranasally, go for it. So it actually works really fast.
And you can give naloxone intranasally as well?
Absolutely.
Oh,
Yeah.
that's awesome. Okay.
Yeah. Just think of humans.
Okay. Right. Of course. Yes.
Yeah. All right. So let's talk about inhalants really quick. We can get some of these done. So we're just going to talk about the ones that we really use commonly, and then we can always go back to the other ones like on Sunday to kind of focus on them. But what are
on Sunday? I'm glad you answered that because
yeah.
Oh crap. Okay, I'm like so behind. Okay.
Yeah, no, you're fine. And it's okay if you're like still catching up, so don't worry.
Is anybody else trying to do this with vet tech prep at the same time? Because I like feel like I'm killing myself.
Yeah, and then working, it's a mess.
Yeah, I don't know
it's
how to
a
do
lot. Yeah.
Yeah, I know.
With vet tech prep, that's a lot. So
I know, and so like I'm slipping, but okay. This is not everyone's problem, it's my problem.
with inhalants, so what inhalant do we commonly use?
Isoflurane.
Isoflurane. Great. So so we have isoflurane. Okay, so what is, and then sevoflurane, right? And then what else did someone say? Desoflurane, okay.
I'm old also, and I worked at a practice that used halothane.
You did not.
Halothane?
I did.
You did? All right, you're
I'm
crazy.
old.
I love it. All right. Gosh. All right, so we'll throw halothane in here. I love that. That's so funny. All right, and it's good to actually throw that in there because I love talking about halothane as the history aspect of things. Okay, so isoflurane. What do we know about isoflurane?
It's liquid when it's not exposed in the air, and then when it's exposed to air, it just makes you lightheaded. For the text, I mean, if you got a gas leak.
Okay. We'll probably do that for everyone.
Relatively low MAC concentration.
Okay, good.
Minimum alveolar.
Yeah. So I think the MAC for it is like 1.3 or something around that nature. compared to some others. So it's not too crazy. Let me just double check if I'm losing my mind on that.
1.3 to 1.63.
Oh, thank you on that. Look, I just pulled that out of my brain.
Whoa.
1.3 times.
And MAC stands for.
Oh yeah, you're right. So we'll get to that. Hold on one second. All right, 1.3 to 1.6-ish, you said?
1.63.
Okay. You're so technical. Awesome. So their MAC is somewhat low, right? And then, which is important to know their MAC, right? Rather than what's the setting on the vaporizer, because every vaporizer is different. So, as you guys know. So, isoflurane is also cheap, correct? It's like $20 a bottle. So that's why we use it a lot. That's one reason why we use it a lot. It's pretty safe too, compared to some others on our sheet here. Does it have a smell?
No.
There's no smell?
Yes.
There's a smell. Yeah. Like,
Smells like
you know when a patient's waking up from an isoflurane because they breathe it off and you can smell the isoflurane coming off.
What does it
So-
smell like?
Isoflurane.
But like, what could you compare it to?
Yeah, it just smells like a gas coming off. I don't know. It's isoflurane gas.
Okay.
Yeah. It's not, I don't enjoy it. I don't know. So yeah, I mean, and then sevoflurane. What's the MAC for sevoflurane? Anyone have that?
2 to 2.5.
2.34 to 2.58.
Okay, 2.4 to 2.58. Now, when we talk about MAC, what does it mean on MAC for MAC itself? Like, what it doesn't mean? Okay, so MAC itself, what does it stand for?
I want to say mean or
Minimum alveolar concentration.
Good, minimal or alveolar concentration, right? So essentially, that means how much of that drug is going to concentrate the alveolar or alveoli, all of them, so that the animal falls asleep. Essentially, the fastest itself, right? So what is it going to take for that animal to fall asleep, right? So that's the way we know the dosage itself, because how do you dose out the gas, right?
Mhm.
So as you guys know, the more and more that you do anesthesia, you probably have figured out over time what maintenance is on isoflurane, right? Just by guessing how animals, or someone has told you, how animals just are maintained on isoflurane. So what would you say, because you probably use isoflurane the most, right?
We use Evo.
You do? Awesome. So, okay, so for isoflurane, what do you guys, I love sevoflurane.
Evo's great.
What do you guys put your maintenance of isoflurane?
1.5 to 2.5.
Okay, 1.5 to 2.5 roughly. So can we just say like 2-ish to take an
Yes.
average? Okay. So I'll just say 2% roughly of ISO. Now how about SIVO?
Anywhere from like 2 to 3 usually.
That's what you maintain them at, is 2 to 3?
2.5 to 4.
Whoa, I never used 4. So
I've used it one time.
Okay.
Generally, we use 3 most of the time, and then like when we get to a good plane, usually we kind of judge between 2, 2.5.
Okay.
Yeah, I go by 2, 2.5.
Okay. So someone said also 3-ish.
We'll
So,
like induce a 3, but then we'll typically go down to 2 to 1.5.
so this is for SIVO.
SIVO, yeah.
Interesting.
Isn't SIVO more potent than ISO?
No.
It's less. It's
Yeah,
less.
less potent. So
You
when
mean
we
more
look
of it-
at,
Sorry.
so when you look at MAC, right, this is saying that this amount right here is how much it's going to take to make this animal fall asleep. So if this amount is lower, that means it's more potent, right? Because that amount is that much it's going to take to make that animal fall asleep, right? So if this one is higher, that's going to make you have to give more drug to make that animal fall asleep,
Okay.
right? Does that make sense?
Mm-hmm.
Okay. So I guess too, depending on what you guys are giving for induction and all of that, that could potentially alter it. So if we say like 2 to what did you say, like 3 maybe?
3.
We can kind of go from there. So when you guys do this, technically, so say you have a new drug that comes out and you don't even know what your maintenance is going to be. Typically, when you guys do like it, you always go based on light anesthesia would be MAC times 1, and that gives you what light anesthesia would be. Maintenance would be MAC times 1.5, and that gives you your percent to run them at. And then for heavy anesthesia, it's MAC times 2, and that gives you your percent. So essentially what you can do is take these MAC dosages, you know, and say, okay, isoflurane, I take, oops, like I erased it. You could take, you know, this number first if you want to like try something lower, and take MAC, that 1.3 times 1 if you want light anesthesia, and that should get you, it'll be 1.3%. Or you could do MAC times 1.5, and that'll get you your percentage for maintenance. I think if we did, that gives you like 1.9 something. So we're pretty close to that too. Sevoflurane, so we have 2.4 times 1.5 is 3.6. So I think that just depends too on like what type of induction meds and your pre-meds and all of that too. So if you guys are maintaining them at a lower thing, you're doing a great job with anesthesia as well to keep them at a lower rate. So yeah, that's a way of like calculating it out. So say you have like a new drug that just comes out and you're like, I don't know what I'm doing with that. All right, so halothane. Oh great. So SIVO, does that have a smell to it?
Yes.
It does?
Yes, it smells
No.
horrible.
Yes. Yeah, you absolutely can smell that.
I don't smell anything.
Yes,
No,
you
because
do.
don't they use those on masking more because they don't have a smell, they don't irritate membranes.
Right. Yeah. So okay, what color is sevoflurane?
Clear.
Clear.
Oh wait, I'm sorry. What color
Yellow.
vaporizer?
Yellow.
Yeah, yellow. What about isoflurane?
Purple.
Purple.
Purple. Good. Okay. What about halothane?
Green.
Thread.
It's red.
No.
Yeah.
Yes.
I'm
I
like,
guess
think
those
back, guys.
purple-
Think bad. Yeah.
Is
I
Des
saw-
blue?
SIVO
Yes.
is
Des is blue, like a light blue. So, awesome. So I did not spell anything with sevoflurane. And okay, so what's a really great thing about sevoflurane compared to isoflurane?
Less irritating to the membrane.
Okay, great. How do your patients wake up?
Easier.
Easier? They just
Okay.
kind of like wake up like, hey. Not
No.
necessarily, no. But do they wake up quickly?
Quickly. Yeah, I
Yeah.
would say quickly. Yes.
Yeah, absolutely. Yeah. It just seems a little bit a little less dysphoric, right? They're still, sure, they're still dysphoric, but they're a little less dysphoric.
Is this the one that you can't use on horses because they do have like a rough recovery? Is this one it?
I'm not sure, honestly, on horses. I'm not the horse lady, honestly. I'd have to look into that for you. I can look
Okay.
into that. But that's a good question. Interesting. Anything else about SIVO? I like that you guys use SIVO in practice. That's great. Oh, it's super costly, right?
Yeah, it's cheap.
Yeah. So isoflurane is like $20 a bottle.
Yep.
SIVO is like $200, $250 a bottle.
Wow.
Super expensive.
And see what we said, it was green or yellow?
It is yellow.
Yellow. Okay.
Yellow.
So
What is green? What is our green gas? Well, it's
That's
not really
oxygen.
oxygen, right? I'm like, it's really not green. The gas is not green, but like it's labeled green. Yes.
But it's the label, or is it like the color of like the stones in your oxygen?
So like the labeling for it, all
The
of
tank itself.
Yeah, like, yeah, right. The tank and all of the lining for it is all green. So.
Okay, so it's not necessarily like the color that it turns the soda lime in.
Right. No,
Just
no,
the
no, no.
labeling. Okay, that's what I thought. I'm like, oh, cool.
No,
So I'm
no.
like, iso, it turns purple. Does it mean
No.
like, okay.
Nope.
So
None of the gas or anything like that. None of it turns any colors. It's just how they're all labeled.
okay, so anytime that the soda lime like is expired, it would turn purple and then turn back to white for all of them.
Okay, so soda lime, here's the deal. Soda lime, yes, will turn purple. It is a old wives' tale that when it's expired or done being like absorbed, that it will turn purple. However, you're right, it will go back to white, and some people miss that purpleness, and so it essentially is all used up, and so your patient will then start inhaling carbon dioxide from the soda lime, which then is really dangerous. So it is important to like make a chart on your soda lime canister or your carbon dioxide canister to change it after every 8 hours of use. So that is 100% important. Every 8 hours. So whether you guys, check it off every 15 minutes of use that way, or every half hour of use, but it's important to change it every 8 hours. And then, yeah. Don't go off of the purpleness. Bad, bad, bad. Okay, so halothane. I can't believe you used halothane. That's so funny. What are some important stuff about halothane?
It's very irritating to the mucous membrane.
Great. It causes what?
Vasodepression.
Okay. Malignant.
Hypothermia.
Yeah, malignant hyperthermia, right? That's like super important to know. Causes malignant hyperthermia. What does that mean?
Overheating the body.
Yeah, overheating the body, right? It's bad, 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 bad. Like super hyperthermia. I mean, it's good to keep the patient warm under anesthesia, but not in a good way. So we no longer use it in practice, hopefully, because it was just really dangerous. Our patients were not, it just was a rough anesthetic event using it. So, all right, so desflurane. What's desflurane like? Like, do we use it a lot in practice?
No.
Right, yeah, it's not really used that much in practice. You see it a little bit more in human medicine, but it's good to know about.
Lower potency.
Yeah, lower potency. It's very, very similar to sevoflurane though. So sevoflurane is kind of the more preferred one in veterinary medicine because it's so similar to sevoflurane. But it's good to know.
So what would be the difference between sevoflurane and isoflurane? Just the pricing?
So sevoflurane and isoflurane, they have quite a bit of difference. Yes, one big one is pricing, absolutely. Isoflurane is more potent.
Okay.
So a lot of times with sevoflurane, you're going to have a smoother anesthetic event just because you can transition your patient through anesthesia a lot easier because you can change their depth very slowly through anesthesia compared to isoflurane. So because of it not being as potent. So we have more capability of like micro changing it, right? Compared to isoflurane, if that makes sense. So essentially it's just a little bit rougher of a ride in isoflurane than sevoflurane.
Cool.
But it's not like it's a bad thing. You know, like isoflurane's not bad. It's just that sevoflurane is just a little bit smoother. You know, it's the luxury ride. All right, so local blocks. We'll finish these guys up really fast. What are a couple drugs that we use for local blocks?
Lidocaine.
Awesome. So lidocaine.
Buprenorphine.
Good. Lidocaine and bupivacaine. All right. So one is the short distance runner and one is the long distance runner.
Lidocaine short distance,
Okay.
I want to say.
Yeah.
That was actually right. Wow. Good
Yeah.
job. Yeah.
Yeah. Pat on the back. So bupivacaine is the long distance runner, right? So lidocaine lasts for about 2 hours or so, but it works faster, right? So if we need to block something quicker and we don't really need it to last that long, we can use lidocaine. If we want something to last a little bit longer, we can use bupivacaine. I didn't spell this right. Bupivacaine. Okay. So bupivacaine lasts about 5 to 6 hours. So when we use lidocaine, bupivacaine a lot in dentistry, of course. So we do local blocks in dentistry. We can do local blocks for spays, like a splash block, a line block. We can use it for testicular blocks, which those are a lot of fun to do, right? Anyone do any of these blocks in practice?
I do testicular ones all the time.
Yay! I love that. They feel so good. Like the animals feel so good as they recover, right? So, I mean, and even in surgery, you can tell during the procedure, their vitals are not as up and down in certain parts of the procedure. At least I've seen that. So it's really nice to be able to help in that regard. So go you, good job. And then there's other types of blocks too. So we have epidurals, which are fabulous. And anyone can, you know, you don't have to work in a specialty to be able to do these too. So you can do them for like C-sections. You can do them if you're doing orthopedics. And then we also have ones like, say you're doing a blocked cat. You could do like a coccygeal block from back there so that you can kind of just block that area so they don't feel that ouchiness of the fact that their bladder hurts right now, and then it relaxes them so you can place that urinary catheter. So there's a lot of really cool little different blocks. Plus, if you're still doing declaws and stuff, you can do a ring block, which some people still are doing. It just depends on where you guys are at. There's also different ways that you could do these lidocaine or bupivacaine blocks by adding drugs to them that makes them last a little bit longer. So we can add in these an opioid.
Epinephrine.
Yeah. So you guys add epinephrine. So what does the epinephrine do? What am I doing?
Prolongs the effect.
Yeah, so adding that opioid in there, the epinephrine you can add in. All right, and then there's also another drug we can add in there. Remember, we talked about dexmedetomidine having a little bit of pain management effect as well. We can also add tiny microdoses to that too. And it can give these patients not only just what we said, having 5 to 6 hours, and this one is 1 to 2 hours of pain relief. It makes it last a little bit longer, so that these guys help with giving up to 24 hours of pain management, which is kind of cool. So this is why, like, when I taught anesthesia, I said, we get to play with drugs. So it makes it fun that you guys can look at these and go, oh my gosh, there's options for different types of pain management that don't always have to be like IV pain management or oral pain management. There's local blocks that we can help with and stuff too. So, all right. So lastly, we talk about our NSAIDs. So how I look at our NSAIDs, the easiest way is that we look at Cox-1s. So the difference between Cox-1s and Cox-2s, and people get really confused, what am I doing? Is that Cox-1s are kind of our old school NSAIDs of being like, they're the ones that can cause coagulation issues. And so I think of like my grandma being like, I need to take my bare aspirin every day to prevent, any clotting issues, right? But Cox-1s still have like that pain relief type of thing, right? So essentially your Cox-1s are like your aspirins. So aspirin, right? So what is like one of those aspirin type of things that we have in veterinary medicine? I mean, yes, we use aspirin too, but do we have another drug that's kind of like that? It starts with a K.
Ketamine?
No. It's really old school. Ketoprofen. So again, this is like one of those things that we can use. Don't really use that often. But it's kind of like these old school drugs that we remember our Cox-1s deal with that coagulation side of things, can help with pain management, but just think of aspirins, right? Like you'll take an aspirin if you might have a headache or whatever, but there's still that coagulation factor to it. Now our Cox-2 drugs deal with inflammation. So this one has coagulation. Like think coagulation when you're thinking COX-1s, and then think of inflammation when you're thinking of COX-2s, right? So when you take a COX-2 drug, this is going to help with inflammation, like how we take, you know, ibuprofen because you have a sore arm from, you know, like sore body, right? You're dealing with inflammation. So what are some of our COX-2s that we utilize quite a bit? And these you'll probably list off in a second. I'm sorry.
Propofol?
Carprofen, good.
Put meloxicam in there too.
Yeah, meloxicam. What else? There's like a ton.
Isn't there one for the cats now? It's
Good, robenacoxib.
Monsieur?
Yeah, it's Onsior, robenacoxib. Yeah.
Mm.
How about what's Deramax?
Definitely in the class.
Aracobics.
Good. I probably spelled that totally wrong, but you know.
what's that? How do you call that? Ribocoxib?
Yep. Oh, I spelled it that one wrong too. It's an O.
R-E-B. Sorry,
It's
I can't.
R-O-B, sorry.
R-O-B. Okay.
You know me and my writing.
I couldn't work out your writing. Sorry.
I know. It's hard to write straight up. Like I need to be able to write up.
Unless you type it.
No, I type all day. It's just horrible. What else? Anything else you can think of?
Methocarbamol?
I'm
I
sorry.
don't know.
Deramax?
Methocarbamol?
Methocarbamol. Not methocarbamol. That's actually a muscle relaxer, but that's a great drug to use. Yeah. Deramax I have on there. Daracoxib.
Daracoxib.
I just spelled it wrong though.
Never heard of half of these drugs. That's pretty. sad.
What? We're gonna have to work on that. Oh, you got a good one. Yeah. The Galliprant we'll get to in a. Oh, you better get the right spelling because I can't spell that either. So, F-E. Okay, so Kelsey, what do we use this drug for? Especially horses. Okay. Large animal. Yeah.
Did you put gabapentin in there?
Gabapentin doesn't go in this category. Gabapentin is actually an anticonvulsant. Weird enough. It's just a
They use
sucky
it
one.
for like gastric pain though.
Gabapentin? It's actually used more for like nerve pain, but it's actually technically an anticonvulsant. It's just a really sucky one. So.
I'm not sure if I'm saying this one right, but Phenobarbitol, butte for horses.
Wait, what is it you just said?
Phenobutazone, like butte for horses. I don't know.
Yeah,
if
butte.
Right.
Yeah, absolutely. I'm like, I think I know what you're saying. Yeah. So butte, right? Absolutely. Yeah. Great. I always say butte. I hate that one. So butte. I make an exception for that one. So yes, to help with colic, good. So this one help with colic in horses. Awesome. Very good. This is so common. So that's great. Awesome. So we have a good mix here, right, of the drugs that we utilize these for. So like these guys are super common that we use, especially in dogs. I guess meloxicam we can use in cats too, but remember, this guy has a black label, right? Black label for who?
For cats.
Yeah, for cats. Yes, we can use it for cats, but it's cautionary, right? Robenacoxib, what do we use this guy for? Especially. Yeah, for cats. Yay, cats have something. We can use it for dogs, though. We can. But why should we, right? Daracoxib, we utilize for dogs, right? Mainly. It's not really used that often. Like, someone has to, like, really like it. I remember when Duramax came out, I, like, went to this, like, big meeting and they gave us dinner and they were like, this is going to be better than Rimadyl and it's not going to have any side effects like Rimadyl and blah, blah, blah. And then then it all went downhill from there. So you can, especially obviously all drugs, right? You can OD on it, long-term side effects, of course. So we still have to monitor liver, kidney values and whatever for all of these drugs if they're going to be on long-term stuff. So it's really important. So these two guys are for our large animal people who really love our large animal. Not my deal. I mean, I like looking from afar. It's great. So they're just a little scary to me. Now, non-Cox drugs. They're still in NSAIDs, all right? But they're non-Cox. So what would that be? Our big one, like our big one that we use a lot, especially now. It starts with a G.
Oh, Galliprant.
Galliprant, yeah, absolutely. I'm probably spelling it wrong. Great. So what do we use Galliprant for?
Arthritis.
Yeah, so it was approved for osteoarthritis in dogs initially, right? Now, we use it for so many other things too. It doesn't have to be osteoarthritis in dogs. We use it as a pain relief for orthopedics and all different things too. But that was what it was initially approved for. And so it's actually a really great drug to be able to use because it doesn't have like these weird side effects in some of these Cox-2s. So it's really nice to be able to use. So great. Good job, guys. Oh, we are a bit over time, but that's okay. It's not like you guys have anything to do, right? What else?
This was very helpful. Thank you.
Of course, of course. I mean, you guys need to see my crazy, horrible handwriting. So it's just the beginning, guys. Just the beginning.
Would you put cefazodine in the...
I'm sorry, what'd you say?
There's one, I feel like there's a non-Cox for turtles.
We don't talk about turtles here. No turtles. No turtles. They're on their own. Yeah.
There's one that starts with the F, I feel.
I have no earthly idea. Anything that doesn't have hair or fur, whatever, like, nope. If they have feathers, for sure, nothing. I don't touch those things.
How about scales?
Maybe.
I'm like,
No, I've had a couple
scales.
birds like attack me before, so like they're on their own. Like, nope. None of that. None of that. I have, since I've been attacked by a couple birds, I did actually hold a cockatoo, but that was a big step for me. So, awesome. Okay, so plan of action is Sunday again. Bring questions, comments, of course. We're going to go over anesthesia, which I love, and any questions about that. We'll go over, anything that you just feel like you don't have a grasp on too. So I know people get really nervous about anesthesia in general. So yeah, kind of go over as much as you can in the content aspects of things. I totally understand that there's a lot of content. So typically that's the beginning is a lot, and then it kind of trickles down so that you have time to go back to things as we go through. So just do your best, and bring any kind of questions that you have for Sunday. So I'll see you guys Sunday morning.
All right, thank you.
Thank you.
Yeah, no problem. You guys have a great night.
Thank you.
Yes,
Get
I
some
got
rest.
it. Savaz, it's called. It's actually an antibiotic, the one that I was thinking
Oh,
of.
Cefazolin.
Yeah.
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 Awesome. Great. Well, we'll talk on Sunday.
Cool. Thank you so much, Beth.
Of course. Take care, guys.
Bye.
Good night. Bye.